Hello and welcome to our session on theories to inform RT and SUD care.
So today we're going to talk about how we can use theory to shape TR service delivery for people with substance use disorders. We're going to talk about 3 separate theories that are relevant to both recreational therapy and substance use disorders. And we're then going to talk about how we can implement these through the APIDE process. We're also going to provide you with an example of a theory-based model for care and discuss some guidance on how to implement this at your individual agencies.
All right, so we have 3 learning outcomes for this session. The first one is that we hope that all of you who are attending this virtual session will be able to understand the benefits of using theory to inform your practice. Second, that you'll be able to identify 3 key theories that are related to both RT and SUD care. And third, that you'd be able to understand the steps in developing theory-based program design. All right, so who are we? Who are these people talking to you today? Jason and I are both faculty here at SUNY Cortland. I have experience working with adults with substance use disorders at an inpatient and community-based levels of care, and my research is on the use of rec therapy in SUD practice.
And I've worked across the human services field at various populations. The last 10 years have been spent in behavioral health, and my research is really focused on recovery and getting folks in recovery engaged in leisure services.
Okay, so theories are not just thoughts that we have that are untested. We're probably used to hearing things like, well, that's just a theory. And when we say that, we mean a hunch. In the context that we're discussing theories now, theories have been tested and created to explain the world around us. They weren't just somebody's good idea, and they can be used as a guide to make us better practitioners. They unify and they shape our clinical decision-making, and when they inform our programming, they can help us by explaining why we can expect the outcomes that we expect. Now, we understand that nobody's going to change their entire suite of programming overnight, but as we identify a theory that can inform our practice, we can start to identify ways to update and change our programs that are grounded in theories.
Yeah, I like talking about theories at this point in my career. I think as an undergraduate, when the word theory was mentioned, my eyes glazed over and I kind of blanked it out. But as I moved through my studies, it really became much more apparent to me how important theories are in terms of development ideas, development of programs, things like that. So if you're one of those folks who, like me at the undergrad level, just kind of zoned out when the word theory was mentioned, I'm going to snap my fingers and bring you back to us, because this, the way we've set up this session is to really give you 3 examples of how theory makes sense to you as a practitioner and how you can use it to improve the programming that you offer.
All right, so let's talk about outcomes. We mentioned in the last slide that theories can explain why we get the outcomes that we're going to get. So outcomes happen as a result of an action. It's a consequence. So program outcomes, it's the consequence of participating in a program. And they're like the overall big pieces. Outputs are smaller measures that tell us if we're achieving the bigger outcomes that we are looking for. So at this point, some things to consider. What would really tell you if your rec therapy program was a success? How would you know? What are your desired program outcomes? It might be a good idea right now to just pause. So hit pause, and I want you to think about this. Really think about what outcomes do you want? Jot down your thoughts. Okay, so what would you need to measure to know if you're achieving those outcomes? Those pieces here that you're thinking of, those are your outputs. What can you measure to know that your program is working? Perhaps pause again here to think about this question. What in your current programming provides the opportunity for these outputs to happen? Let's think of one example. I want my participants to find something that allows them to feel fulfilled through their leisure time. In order to feel fulfilled, what do my participants need to learn? Well, one big piece would be my leisure awareness and appreciation, right? Because if I don't know what leisure is, or if I do not think it's important, then I cannot feel fulfilled through it. So my programming would need to include leisure education that teaches about what leisure is and its benefits. Then after that, there needs to be opportunity to try and learn the leisure that folks are interested in.
So as I mentioned earlier in the presentation, we're going to look at 3 different theories today. We're going to start out looking at family systems theory, then we're going to go on to broaden and build theory, and then we're going to finish with constraints theory. We're going to give you a bit more in-depth information on each theory, then we're going to work or look more closely at broaden and build theory and how we implement that in a program setting.
So family systems theory is not an uncommon theory to use in rec therapy practice or in the treatment of SUD. And family systems theory, in this theory, we always look at the person in context of the family and in context of any other systems that have an impact on them. So the idea is that people who are in treatment for a substance use disorder, they're there because their symptoms occurred as an attempt for them to find balance in the family system as a whole. So in this model, the family functions like a mobile. So as one piece is moved or shifted, the rest of the entire mobile moves and shifts as well to restore balance to the whole thing. This theory is used to explain the impact of a parent substance use disorder on a child or on children, and it also helps to inform why return to use may occur after treatment. So in other words, if a person goes into care, they receive treatment, they achieve that first step of being in recovery, if their environment or if their family system hasn't changed, it'll be very difficult to maintain that change within the system.
I think what's nice about this model is it doesn't remove someone's autonomy within the system. It just acknowledges that that autonomy is affected by what's going on around them.
Yeah, I really think that's important too. It's a good blend of a person being able to focus on their individual stuff that needs to happen, but also acknowledging how treatment really needs to tie in with the family to have long-term effects. All right, so SAMHSA Tip 39, if anybody's not familiar with SAMHSA, it's the Substance Abuse and Mental Health Services Administration, which is a part of the United States Department of Health and Human Services. And they have a series of guides to help implement things into practice for behavioral health. And SAMHSA Tip 39 includes information on how to include the family in care for substance use disorder. And there are 3 key practices discussed in this guide that could be relevant to RT and could be applied to RT, although they are not RT specific. And the first thing would be to use language that is family oriented in your programming. The next thing would be to link clients and their families with community resources. And the third thing would be to develop a family-friendly environment for care.
I would just make the additional note that the SAMHSA website is really good for new professionals who want to, if they're starting out in SUD or they've just moved into the behavioral health field, check out the SAMHSA website. There's lots of really good resources on there. They're free, you can download them. So yeah, take advantage of the SAMHSA site. It's a really good resource.
Yeah. So broaden and build is, it's not a new theory, but it's newer to the recovery movement. Broaden and build is part of positive psychology, and it's, like I said, it's new to the recovery movement. And there was just an article that came out in 2021 where a thematic analysis was done, and they noted, this was about SUD care, not rec therapy specific, but it was noted that outcomes from care that were based on flourishing were positive, and that participants themselves, they reported how different the experience was contrasted to the different types of treatments that they had engaged in that were not based on broaden and build or not based on positive psychology. So broaden and build theory suggests that experiencing positive emotions builds resilience, and it encourages the exploration of new things. So this results in a broadening of experience and interest and results in an upward spiral. So in other words, if I have an opportunity to try something new and I do good at it, I'm successful at it, I'm going to have positive emotions, which are going to improve my resilience and will encourage me to try new things. And in recovery, that could look like learning a new leisure skill, having success, thinking more highly of myself as a result of it, being willing to try another new leisure skill or to step up the leisure skill that I'm participating in and then have success and try again. And it just naturally broadens the leisure repertoire instead of keeping that very, very narrow focus in recovery.
I like this model. I think it's like the anti substance use disorder cycle. Because when you look at that model, it's a downward spiral. It has a few positive outcomes. When you're thinking about broaden and build, it's much more focused on what life can be in recovery and how we can build that recovery capital and help the individual kind of recognize some of their own strengths and build from there. So I think it very much ties with SUD, and it's kind of funny to me that it's taken so long for it to become accepted.
Yeah, it seems like the natural counterpoint to SUD. I totally agree.
Yep. So the final theory we're going to look at as part of this presentation is constraints theory, and constraints theory was an intentional choice. So much of the work that we do in rec therapy tries to look at the positives, and on the face of it, constraints theory doesn't seem to do that. It seems like it's not going to focus on that. So I wanted to include this theory to show you that it's how we work with someone that makes the difference. So before we get to that, I want to sort of explain that the three types of constraints on leisure participation, as outlined by Crawford and Godby, are intrapersonal, interpersonal, and structural. So intrapersonal constraints are our own self-doubts. They're the things that stop us doing things. If I get up on stage and do karaoke, I'm going to look like a fool. All right, and so I'm not going to engage in that activity. The next one is interpersonal. We'll stick with the karaoke example. If I get up on stage, not only will I look like a fool, but people might heckle me or tell me I'm a bad singer. And so again, I'm not willing to put myself in that position. And then there are structural concerns, which not being able to get to the venue to do the karaoke because there's no transport or there's a financial implication, those kinds of things. So when we're thinking about constraints, there are these three levels that we have to think about. And so from a substance use disorder perspective, when we're working with our folks, it's kind of very easy to see where some of these things may arise. So there's intrapersonal constraints, that low self-esteem, the poor self-concept that people have, especially as they're coming off substances and they're sort of reevaluating their lives and they're being given very mixed messages by some of their supports. That can be a really big impediment to them wanting to go out and try new things. The interpersonal one, again, how are they interacting with folks? If you're not feeling confident in a social setting, why are you going to want to go out and engage with other folks, right? The tendency to isolate is a very strong one, certainly in early recovery. And so this one is, again, a clear constraint. And then structural. We shouldn't ever presume to know what structural constraints someone faces when it comes to leisure. We shouldn't say, oh, I'm not going to talk about this choice of you because you can't afford to do it. That's a decision that the patient, the client needs to make. But there are real structural concerns, especially if they're living in supported housing programs. Maybe there's a curfew or there's a limitation on how much money they can have, all of these types of things. And so that's a lot of problems I've just thrown right up, right? Yay, problem-based thinking. But here's the thing, when we're looking at those problems, the flip of that is an opportunity, right? And there's an opportunity to find strengths that people have and have those conversations and help them to find some of that resilience, right? So even the intrapersonal things, sticking with the karaoke, why is that a challenge for you? What kind of things have you done in the past where you maybe have had to put yourself out there? And we can have those conversations and turn it around. So again, the constraints theory is here really to have that kind of conversation. It's like, yes, this does focus on problems, but we as therapists should be able to look at the strengths of the individual and work with them at that level. And I will add at this point that these are just 3 theories that we've selected based on our experience. There are many more out there, and some you may be much more comfortable working with, or more knowledgeable, about. So obviously feel free to look for yourself and find out in the literature.
All right, so theories, they explain behaviors and they explain how behavioral change happens. They're really the lens that we can use to look at our practice and to understand why we're doing what we're doing. So we also just wanted to mention a couple quick resources that you can use beyond this this brief training. And so the first thing is Porter's textbook on theories in rec therapy practice. It's an excellent resource if you want to be able to look at theories that are relevant to RT as a whole. So maybe you work in SUD and with other populations, and you need something that you can use, you know, across different populations. Or maybe you just want to find one that really feels comfortable, and the 3 that we're going over don't hit that spot. You can use that book to really dive in to shape the care you provide. Also, the Anderson and Heine textbook, the Therapeutic Recreation and Strengths Perspective, it has more solid information on theory guiding practice there. So either one of those would be great resources. And last, don't forget to reach out to faculty at academic institutions, or to use your interns as a way to access academic journal articles on theory that might be behind a paywall for you. I know Jason and I are happy to help. I'm sure most people are. We want to get those materials into your hands. All right, so we're going to chat for a minute here about the intersection of APIDE and theory. So remember, APIDE is the process of providing care, and your theory informs the care that you provide. APIDE isn't a theory, it's a model. So how do these things intersect? Where could confusion come in? Jason, what are your thoughts?
I think in part it comes back to the comment I made earlier about when we're talking about theory, it's very easy to just kind of zone out. And so we're assuming that this model is a theory. And I think also a lot of theories do have models. So it comes as gray area of like, oh, okay, so this is a theory, this is the theory that I use. But when we do that, certainly in TR, I also think there's like that exclusivity idea of TR as the only profession that uses this, which isn't true. But because of that, it's like, oh, this is our guiding theory. And as is rightly said here, it's a process, it's a model that we follow, but there are other inputs that make this model work. It doesn't just function on its own to the best of, best version. So I think there's a couple of different things going on there.
I think that's well said. I think also, like what you mentioned is really important, that it's often multiple pictorial representations of what we do, and it's easy to get lost between all the diagrams. The other thing I think we really need to remember too is that a theory, if we're looking at a theory, it's a broad level conceptual explanation for what we do across programs. And APIDE is really what we're doing at the individual basis with a person. So we can really think of them as like macro and micro level for how things work. What do you think about that? Would that work?
Yeah, I sort of just, as you're talking, I'm thinking, you think of assessment as the body and the theory as the clothes the body wears. Like that's the kind of how they kind of work together, right? Like they work together. But without that, or this is the skeleton, on which everything else hangs, like that kind of idea. So, and the nice thing is we can dress the skeleton up, we can dress the body up however we wish, just selecting the appropriate theory for our population, for our environment, for the setting we're in, whatever. But we've always got to remember that the APIDE model is just that. It's a framework that we can use to build everything else upon. It's not the end of the process.
Right. It frames our services. It doesn't necessarily say why we're providing the services that we're providing.
Right. And I think that should become clearer once we get into the building of a program. At least, we're trying to provide generic examples. so that you can kind of take them as, we don't want to give you a math problem that makes no sense when you get home, right? So we're keeping it fairly
Right.
generic, right? The teacher
Jason, you just said math. I think we're all going to glaze over again.
Yeah, no, I'm gonna click my fingers. Yeah, so we're trying to keep it fairly generic, just to give you some ideas. But then you should see how these 5 steps really work and how you can tie your theory into them as you go. All right, so what does assessment driven by theory look like? Really, the assessment that you do should be measuring the same outputs that you're looking for in the evaluation. These two things should always be connected. That's what gives you any kind of meaningful data. Your assessment should only include information that's relevant to your practice and to the care that you can provide, right? So a challenge for us in SUD is that there isn't a standardized tool, assessment tool for us. So that often means we're basically drafting our own stuff, which isn't ideal. And hopefully over time, as we develop some collaborative research models, we can amend this. But for the time being, it means we're working a lot using in-house stuff. So it's really important to remember that your assessment should be aligned with the theory that you have decided to use as your practice theory.
Yeah, and I think that also it might already be the case that a lot of you who are listening already do have an in-house assessment, or there's one standard intake assessment that maybe just asks a couple questions about somebody's leisure experience. But I think that, Jason, we can't emphasize enough that assessment and evaluation should really mirror each other. But also, when we think about our rec therapy assessment and asking things that are only relevant to our practice, think about the umbrella and the scope of the agency that you're working for, and make sure that your rec therapy practice is designed to be within that umbrella and not a satellite off to the side.
Yeah, I think it's also about being cognizant of the location, of the environment, if you're discharging folks, where are they likely to go? What's going to be accessible? Those kinds of questions, I think, are really, an important element within the assessment. And making sure that they're given the tools that they need during treatment, so when you come to the evaluation, you can show progress.
Yeah, absolutely. I totally agree. All right, so planning that is driven by your theory. Your individualized planning and your overall program design, both of those things should be grounded in the theory that you have identified. So we're going to walk through, after we talk about the API process in generalities, with an example of these things. But just to get you thinking, so if the goal of your program is to help folks to experience is the goal to help them experience positive emotions, is the goal of your program to develop an identity that's grounded in recovery, is the goal of the program to create change in a family system, whatever your planning is, it should reflect what your rec therapy department is there to do. So once you identify a theory, make sure that the goals at the individual level and the objectives at the individual level, as well as your programming goals and objectives, are all grounded in the theory that's driving your practice. Remember, theory predicts outcomes. So if we ground that planning in our theory, we're not going to grind our planning. It's not a good cup of coffee. But if we ground all of our planning in the theory, in that model that we're using, it can predict the outcomes that we want to see.
And I think that involves using, language that relates to the theory, making sure that if, we're talking about strengths-based or resilience, that those are the words that get put into our literature. And it's also the language that we should be making sure, if we have staff working with us, that they're using that language, so that there's a frequent exposure to the kinds of language that we want people to be using that relate to the work that we do. Is that fair?
Yeah, I think that's fair.
So when it comes to implementation that's driven by your theory, it's really important to remember that, we have to deliver all interventions at a certain frequency and duration, and often that's prescribed by the type of program we have. But within that framework, are we going to be able to achieve the outputs that we've designed our program for? If we only have a couple of weeks to work with an individual, Are we really going to be able to get them re-enrolled into an educational program, or get them driving lessons, or whatever it is they might need to facilitate access to an activity or something like that? So we have to be kind of really mindful of, what are we setting as our targets for the individual, and what's our program setting them up for? Are we making sure that our comprehensive and specific programs are grounded in the theory as well? And again, that comes back a lot to the type of language we're using, but also what are the interventions that we're actually planning for them to do? Do they make sense within the context of this model? While broaden and build may benefit from journaling, maybe looking at something from the constraints theoretical lens, maybe we're looking at more community work or community-based work, so someone can go out and try these things. And again, that's going to be determined a lot by what you can do within your program. If you're working within a closed inpatient setting, clearly going out into the community to try using the bus isn't going to be the best approach to, you're not going to be allowed to do it, so it's not even going to be an approach. So just thinking about those kind of aspects. And then what steps do you need to take to make these things happen? How do you actually go from currently operating in a program without theory to implementing theory within your programming? What can you keep, what still works, and what might need to fall by the wayside and be replaced by alternative interventions? What are your thoughts on that?
Yeah, I think thinking about the steps to make this happen is really important. And this is not a critique of existing programs. This is saying, here's how we can elevate practice, right? You may well have a lot that you get to keep, and it might just be rearranging. But there might be times where we realize that the things that we've designed or created just don't fit with the theory that we fit with, that our practice fits with. And it might be, that we are able to, maybe it makes sense to roll this out following the API process. Maybe it makes sense to change your assessment first. Maybe it makes sense to start working on one specific program first. After, maybe it makes sense to get a whiteboard and draw out your comprehensive program design, and then look at how all of your specific programs fall under that framework. I think a lot of this might depend on what kind of a learner you are. Mm-hmm. So maybe you're like me and you need to spread everything out on the floor and floor organize your program and see it there. Maybe you're somebody where it really helps to draw a picture. Maybe you're somebody who needs to open up Microsoft Word and write out your thoughts. Maybe you need to journal your thoughts and expectations. Maybe it means that you need to sit in clinical supervision and bounce ideas off a clinical supervisor as to how this can improve your programs. I think there's a lot of different ways to change. I don't think there's necessarily a correct or incorrect path forward. I do think it's appropriate to expect growing pains as you do change your programming. And I think that there may be frustration as you implement change. Mm-hmm.
I was going to say, I think that also this is the part where it's really important that you have stakeholder buy-in from your administrators, because this is the part they'll see. If that makes sense, they'll be the ones who will walk past your group room, and this is where they'll see what you're doing. So really, before you get this far, you need to have kind of addressed this at some level with your stakeholders. The assessment will take care of some of your clients. That would be great. You'll get feedback, you'll get information. But in terms of administrators, that can be a little trickier. And so having an idea of where you're going to go with this process, if you're going to need to make significant changes to programming, you're probably going to want to run that by folks, depending on obviously your organizational structure. So I think that remembering those steps can be a really critical part of the whole process, not just at the implementation level, but all the way through, as we thinking about how can you get people on board.
Mm-hmm. Yes, I like that.
And so ironically, as we've reached the end, we go back to the beginning, right? And we're tying evaluation and the evaluation of our programs on outcomes really based on the assessment and what progress the individual has made during their time with us in our programming. Have we addressed the things that were outlined? Okay. If we haven't, then what exactly are we evaluating? If we don't tie it back to that assessment, what have we done? We should have established some clear goals. We should have had some clear criteria, making those goals measurable and specific. And so we should be able to evaluate really quite simply, if you will. The process is complex, but the actual evaluation part should be relatively simple. Have they met this or not? And that's ultimately what it will come down to. Now, obviously, there are shades in there, right?
Mm-hmm.
They kind of did this. They didn't make this goal, but this is what they achieved. So we can still show progress. And I know for the New York State OASIS system, they started to become much more focused on full achievement of goals. And they started taking out things like partial achievement, because that wasn't the purpose, right? A partial achievement is, kind of Ricky Bobby-ish. Second is the first loser, right? So, this was kind of the thinking here. So have we set the goals right for the individual? If not, and if we're finding consistently that individuals we're working with aren't meeting goals, then we really need to think about the goal setting process and the assessment that we're doing right at the very start of that individual's programming.
Yeah, and I think something to really keep in mind is who is coming up with these goals and objectives. Too often it's practitioners who are busy and come up with goals and objectives and show them to their participants instead of sitting down next to their participant and coming up with goals and objectives together. The other really key piece here is that sometimes we start on an objective in our own lives. We've all done this, I'm sure, but we start on something, and once we start, we go, oh wait, no, this is not actually an obtainable goal. Like, this sounded obtainable, but perhaps not, and I need to reevaluate the goals that I have. We should not be getting to an evaluation point and saying that the goal was not achieved. At some point along the way, there should have been signs that we were not meeting objectives. And there should have been discussion with the participant about, hey, what's going on? Is this an objective that you're actually aiming for, or was my practitioner bias there? Is this something that we need to change or adapt? Just like the overall treatment plan, your rec therapy plan is a living document that can be edited and changed throughout the course of a stay. So routine check-ins towards those individual goals and objectives ensure success.
Yeah, and it's also, as you were talking, I was thinking about also, thinking about evaluating groups as well. So yes, the individual is doing this, but we also have to take that time to evaluate the groups that we're using and the interventions we're using within this process. Do these activities, do these interventions really meet the needs of our program? And maybe that's what's the problem. The goal you set was realistic, but the interventions you were using, maybe they weren't as effective. And that doesn't mean you get rid of them altogether from your program necessarily, but maybe for this group we didn't quite hit the mark.
Yeah.
So there are a lot of variables, but having the evaluation and the assessment closely tied together will allow you to get a sense of where things are going.
Yeah, and you can even consider using your assessment as an evaluation tool, right? See, has the score changed on your assessment? Have you moved that, have you moved the needle, right? And looking at, has a measurable change happened in that way? There's no reason why you can't use redo your assessment to see how things have changed.
I think that's always one of the challenges, is when we ask people what they do for leisure. If you're in an inpatient unit, that's not likely to change.
Right.
So I think we have to really think about the types of questions that go on our assessment. As we've already said this, but it's
right.
At this point it kind of makes sense to go back over that and really tailor that evaluation to what's realistic.
Right. Like
what are we going to teach this person? What are we going to work with them on?
If you're working with somebody, in a long-term outpatient setting where you'll get to work with them for a full year, you might have very different outcomes that you would expect than working with somebody in a 2-week inpatient stay. So being realistic and encouraging your participants to be realistic as to what's achievable.
Yeah, maybe asking questions around, what resources they have to access things, or what things they're aware of in the community, or just very kind of general assessment of questions to see where their understanding or knowledge is. And then in the evaluation, hopefully if we've done that kind of leisure ed program as an intervention here, you should be able to provide you with some more comprehensive answers.
Absolutely.
All right, so documentation, everybody's favorite part of this process. It gets put at the end, but it's, you're all aware, nothing really happens without documentation. If it's not written down, it didn't happen. So we have to really pay attention to our documentation, and staying on top of it is a critical element here. But also thinking about that theory and the language you're using, the way you're framing your program. Does that reflect in the documentation that you're providing? Thinking about the ways we describe the individuals that we're working with. Are we looking at overcoming barriers? So the 3 examples here, right? So thinking about overcoming obstacles and barriers to recreation and leisure as part of your constraints theory program, or broaden and build. How are we discussing that upward spiral and people developing and growing through the activities and interventions that you're running? Then family systems theory. Are you talking about the family? Do you do family sessions? I would posit at this point, if you're not working with families, family systems theory may not be the way to go. But that being said, like paying attention to that and being able to document that you're having regular phone calls with the significant other as part of an intervention process, or thinking about journaling some of our positive experiences during our stay in treatment, or just talking about how we can use the bus system in the city that we live in, or how we can access Uber or Lyft or whatever it might be. Making sure that stuff is documented and it's in line with your assessment, with your intended outcomes, and that the patient is present for that documentation process and sharing their thoughts too.
Yeah, I totally agree with all of that. The other thing is that so often we've been trained in our clinical documentation to not be strengths-based, sometimes because of issues around third-party reimbursement, right? Just be mindful that we can still implement documentation that's driven by theory using the language and the ideas without pretending that folks don't have things to keep working on.
Yeah, I think you can say patient or individual or Jim has a good understanding of connections to local transport services. However, further work may be needed to talk about income or something, how to pay for these services. I think it's about making clear that there is still work to be done. And as we know, the insurance-driven, healthcare system that we have, making that point clear, as Jackie says, is 100% right. You got to still show there's a need for care and treatment. So yeah, the documentation becomes your best friend in that sense.
Yeah.
All right, so at this point we're going to move on and really get into that example of using theory through the API process. And hopefully at this point you'll start to see how these two things work in concert with the theory and the process.
All right, so we decided to use broaden and build theory as our example for a couple reasons. We kind of mentioned before earlier in this presentation how that positive upward spiral of change is kind of the opposite of the downward spiral of SUD, and so these two just the way that we view the world, these two seem to naturally fit together, and that's why we picked broaden and build. It does not have to be your pick for how you base care in theory. It's just what we decided would be a cool application here. So we mentioned before on our slide on theory-based assessment that the assessment that you should be, that in the assessment you should be measuring the same outputs that you're looking for in evaluation. And you are likely going to be creating a non-standardized assessment made by you. And these are some things that you can include in your assessment if you're using broaden and build theory. So first, you could use positive thoughts. Ask your folks, are they experiencing positive thoughts? How frequently do they have positive thoughts? What are their positive thoughts about? What type of positive thoughts do they have? You should ask about, are they willing to try new things? Is there a willingness to attempt a new leisure pursuit with supports? And any answer to these questions is okay. But where are they in positive thoughts? Where are they in willingness? And then we can also look at their current self-concept. How is someone viewing themselves? So a non-standardized assessment does not have to be a weak assessment. It does not have to be surface level. You can really put some time into these assessments that you're building. And if you're following broaden and build theory, these are places where we would expect to see measurable change in theory-based care. So they're great starting points to include in your non-standardized RT assessment.
I would add to that, all of these ideas should be defined, and they can be defined from the theory itself. So,
Exactly.
what is a positive thought within the broaden and build theory? What does self-concept mean? And B, it's important for your assessment and for the reliability of it that's consistent. Like, how are you going to be measuring this by person by person? So again, you can use the theory to really set up what the definitions of these terms and ideas are.
Yeah, and so remember in broaden and build, it starts as positive thoughts improve resilience. It might be a really hard thing to say to somebody, or a really hard question for a participant to answer. If we ask them, how resilient are you? I don't know is likely to be the answer that we receive. So, we want to get at those concepts through other questions.
Yeah, and I think that's a really critical element.
So our planning, if it's driven by broaden and build theory, it again should be grounded in that theory. So we need to think about therapeutic interventions that are designed to improve and promote positive self-concept, mindfulness, recognition of our thoughts so that we can train ourselves to realize when we're having positive thoughts. And we also need opportunities for new leisure skill development. So, if you're thinking, hey, broaden and build theory sounds really cool, think about, does your current suite of programming provide these opportunities? Is it a chance to develop positive self-concept? Do you currently have groups that are structured around mindfulness? Do you currently have opportunities for folks to go out and try something new with the supports in place to help them succeed at that new thing?
So implementation, so are interventions that are being offered really correct for the frequency and duration to make a difference? So given the time frame that we're working within, does this intervention make sense? We can kind of flex around a little bit. If we only meet with our individuals like once a week, we can do interventions and assign certain homework assignments and things like that to kind of get around that. But if we're working on a really tight timeline, that can be more challenging. So we really have to be cognizant of that. Also, if we're working with a family, how many times a week can you really talk to a family member? How many times may they be able to access your program? All these kinds of things. So there are really important considerations there. Also, in terms of not just frequency, but that duration. If I'm working with someone once a week in an inpatient setting, I may only work with them 3 times, if I'm lucky. Increasingly in New York State, we're seeing inpatient stays of less than 21 days. So I may not even see them more than twice. So what can we do realistically in that time that makes sense? What can I do to get the most value for that person out of the time I have with them? Are we giving a person the opportunity to attempt? And more importantly, are we giving them the opportunity to succeed in a leisure pursuit? And again, succeed is kind of a flexible term here, right? What does success look like? If you only have a couple of days with someone, that's a very different model to if you have a few months with someone. So again, tailor that idea of what is successful to the time frame that you actually have. Are you giving ample time to reflect on positive thoughts that come as a result? What does that mean? Sometimes you'll participate in a leisure activity and the next day you're buzzing, right? You feel good, you're energized. And then another time you may only feel that kind of that intense enjoyment like for an hour or so afterwards. So what does that look like? Think about that in terms of when are you going to ask the person how they feel? When does that conversation take place? Is it something that you can do a couple of times to get some really good evaluative data that you can discuss with them? and are folks given more opportunity to grow? And so that's really where that conversation comes in. I can have a really good experience, but it's not until I maybe sit down and process with someone what that experience was like that I kind of reflect on it and have a chance to kind of analyze what my feelings were, to think about what that activity meant to me, how I could implement or access that activity beyond this program. So I think that's kind of in a nutshell how we can think about that implementation aspect.
All right, so when we're looking at evaluation that's driven by theory, we really want to remember, have we addressed the things that we outlined in our assessment? Because those two, they go hand in hand. Assessment and evaluation, they're looking at the same things. So in this case, looking at broaden and build theory, did we have a change? Do we have more positive thoughts? Are we having positive thoughts more frequently? Are we having positive thoughts about more topics? Is there a change in willingness to try new leisure? Maybe we've moved from willingness to excitement to try new leisure. What's the intensity around feelings about new opportunities in their recreation life? And also what's going on with self-concept? How are people viewing themselves? How do people talk about themselves? Please be specific in your evaluation. So this really needs to tie back to the individualized goals and objectives, right? Make sure that you're comparing somebody to their own baseline of when they came in for care.
Yeah, and I think also thinking about the idea of someone who's maybe being less than successful, I think we have to be objective in how we look at that from the evaluative perspective. Was it because the goal was inappropriate or not achievable in the time frame, or was it because they were choosing not to do the work? And what does that mean for how we're setting up the goal, right? So there's lots of factors there. Sometimes, yes, it's about adjusting a goal, but sometimes that's not feasible, or we have someone who isn't putting so much work in because they're not motivated by the process. So there are lots of variables there, and I think it's important that we learn from the evaluation, but we don't let it define the whole plan, the whole process, because using this theory is going to work more often than it's not, as long as we're being realistic in what we're setting up the individuals to do.
Yes. So thank you so much for listening and being a part of this presentation. We really hope that this is information that you can take and implement at your work site to improve your practice.
Yeah, and I want to thank you also, and also just remind you that we provided 3 examples of different theories. There are many more out there, and once you get into them, try to find the one that fits best with what you're doing, that's of most use to you and your clients and your program overall. There is a reference slide that follows this, but other than that, we're done. Thank you very much.
Yeah, feel free to reach out with any questions.